Hello, everyone. Welcome to this webinar. In today's webinar, I'm going to discuss about what happens when we stretch a muscle. During this webinar, if you're having any questions or comments to make, you can type in your questions in the comment section over there or in our Facebook page. Okay. In this webinar, as we have put that before on Facebook also, that we're going to discuss about what happens when we stretch a muscle. What I mean by this question is that physiologically and mechanically, what changes that takes place. And understanding those changes will help us to grasp how exactly the stretching is affecting the muscle. Okay. Stretching is a commonly used technique in clinical practice. As clinicians, we all know that this has been, we routinely use stretching to improve range of motion or reduce muscle stiffness, which is often a common problem for many of our patients. It's used in rehabilitation, musculoskeletal rehabilitation, post-fracture mobilization, very commonly used, and in neurological conditions, stroke, cerebral palsy particularly, and in sports and fitness also, these techniques are commonly used. So this part of this using common stretching in a routine practice also means that we believe or we believe that stretching is producing good results. So some of you might have participated in the pre-webinar survey. I'm just putting the results over there. When we asked two questions among few other. One of the first question we have asked is whether you use stretching routinely, and what are your views on stretching producing good results for my patients. As you can see that only 10 to 15% of patient respondents have actually disagreed, which means that most of us are using it, and most of us clinically seeing the benefit of stretching in terms of reduced stiffness and increased passive range of motion. It's a simple logic that if it doesn't improve, then we won't be using it clinically. However, there is a caveat in that. As clinicians, as much as we use, we are also aware that in certain situations, in some conditions, stretching does not produce the results that we expect. If you take an example of post-fracture mobilization, stretching and mobilization is commonly used to improve mobility, improve range of motion, reduce stiffness. And as clinicians, we see there is a good result. That is, when we apply stretching, gradually patients' range of motion gets better, their mobility gets better. Eventually, many of them return to their previous functions. However, in some cases, I can give an example of, say, for example, if you are doing post-fracture mobilization for femur fracture, where reduced knee flexion range of motion is often a problem. But most of us are aware that we are not able to regain the complete knee flexion range of motion. Personally, in my experience, I can say that mostly with about close to 90-degree, the knee flexion, we are not able to gain beyond that. And it may be true for when you have a fracture of humerus also, elbow flexion range of motion, as beyond certain level, it's not improving. And in neurological conditions, in stroke and cerebral palsy, we deal with this problem on day-to-day basis. And most of us are aware that the upper limb contractures often doesn't respond to our stretching. So the question that I want to raise, or I want you to look into, is that stretching, a commonly used technique, does produce clinically observable changes, but at the same time, on some condition, it's not producing. So this is the issue I want to focus on. So why does stretching works at some cases and doesn't work? Now, for us to understand this question, we have to get to know what happens inside. I mean, physiologically, biomechanically, what is happening. If we understand that, probably we'll be able to answer a question such as why it works in certain circumstances and why it doesn't work in circumstances. So I'm going to explain what happens in muscles from biomechanically, what happens structurally, and also neurological explanations for the improvement that we see in some cases and improvement that we don't see in certain circumstances. The structural changes that we'll go back to mechanical first, and I think we can come back to structural next later. Okay, yeah, the mechanical changes. That is, we have to understand that reduced stiffness or improvement in range of motion that we get. Right? When we are stretching, we have to understand that the structure that we are stretching. And I think most of us are aware of the skeletal structure, the internal architecture of the muscle, and what it is made of. The muscle is made of connective tissues, extracellular matrix, and the myofibrils, and so on. The common characteristics, structural characteristics of this different architecture is that it consists of collagen, elastin, and other structures, which makes this muscle as a deformable material. That is, under stress, this tissue deforms, which is a common characteristic of any structure which is elastic, which has structure property of elastic. So whenever you stretch a structure which is elastic, so if you can see that this is just a rubber band being stretched. So what happens is when you are stretching it, the length increases, but when the stretch force is removed, the length comes back to its original position. So this is something, one of the explanation that is often provided, that there is a mechanical change, but this change that we often see is a short-term basis. That is, when we stretch, we feel muscle is relaxed. I think most of us would have experienced that when you are taking the muscle to the end position and then hold it over there for some time, and then we are feeling there is some sort of relaxation. And when we do repeated movements and just push over there, there is some amount of relaxation that we feel, which is often seen as the effectiveness of stretching, that the muscle relaxes, which we can gain some range of motion. But the problem with the mechanical explanation is that it is a short-term, immediate changes that we're able to see. That is, changes are seen immediately after stretching or maybe after a few hours. But many studies looked into it and found that in a long-term change, after a week or even after a few days, the range of motion or gained or stiffness reduced often comes back to its original position. But this is this explanation, so therefore, doesn't hold for the clinical changes that we are observing. That, as I explained before, we discussed before, that in post-fracture mobilization and few other conditions like spasm and so on, when we stretch, we are feeling some relaxation, but in some cases that relaxation is sustained. It doesn't come back, but in some cases it comes back. So we have to understand this mechanical property explains why it comes back, because we are stretching a structure which is a deformable material, and whenever that force is reduced, or force is removed, it comes back to its original position. Also understand that the amount of stiffness reduced or stretching, that is the length that is regained, depends upon the force that is applied. It's the Hooke's law that states that more the force we apply, bigger the extension, and also that when we remove the force, it is removed. So the short-term changes that we often see is due to mechanical properties, and it returns when stretching force is removed. So the next explanation, possible explanation that we can see now is, which is now proposed, is the neurological changes. That I've just said, in some cases, the relaxation or decreased stiffness is sustained. The mechanical changes in mechanical properties doesn't explain the sustained changes that we see in post-fracture mobilization, or in some condition. But so they have looked into and found that the neurological explanation is more plausible to explain how the changes are sustained, or even the short-term changes can be explained by that. See, in this picture, which I've given a common muscle that we stretch clinically, that is hamstring stretching, you can see that stretching. So when we are stretching this muscle, the point at which we stop often depends upon when the patient says that no, it's painful, I can't move beyond that, or as clinicians we ourselves feel the tightness, beyond which it cannot be done. Clinically, we often assume that this position is also indicative of the length of the muscle. That is, muscle is short, beyond that it cannot be pushed. So constant pushing, or our treatment that is given, often assumed to increase this length. But we need, when they've looked into studies which have shown improvement in range, they found that the muscle length is not actually increasing. But what is causing this improvement in stiffness or range of motion is that there is the change in the sensory perception. That is, our patients or often have pain at the end because they perceive a damage beyond which that it will hurt. But as a clinician, as a professional authority, when we are doing this repeatedly, that also sends the information to the patient that it may not be a threatening movement. It may not cause damage. So patients get adapted psychologically that, okay, this is not actually going to make worse. And that often makes that they relax more psychologically, which explains the release that we feel. And also that when we are repeatedly doing, there is a neurological adaptation that takes place. That is, in fundamental neurophysiology, you know that if you keep doing a particular thing repeatedly, the nervous system response may not be the same, but if it's done repeatedly, it often adapts. So these two reasons are more plausible reasons for which we have evidence now that the increased range of motion we often observe during while we stretch, and in some cases it is also sustained, and that is because there is a change in sensory perception or stretch tolerance, a word that they now using, which is explaining this reduced stiffness, not necessarily that there is a increase in lengthening of the muscle. So neurological changes or probably at this point of time, or the explanation which has certain amount of evidence to support that. So if you can apply, if you can just use this explanation in patients with post fractures, that their movements are reduced, they have a stiff wrist or stiff ankle, not necessarily because muscles have shortened. It is because immobilized, they are feeling pain, or they expect pain, so they're holding it in that position. But when we as clinicians move it, the patient relaxes because they start realizing that it need not be a threatening movement, or they can actually get better. So if they don't perceive damage over there, the sensory perception of that movement changes, and they get adapted to that movement, which often that we see clinically as a reduced stiffness and also reduced pain. So this is another explanation which has certain level of evidence that explains the short-term changes that we are seeing in patients with muscle stiffness or tightness. And this also explains to a greater extent the long-term change, even though we don't clinically we don't see much of long-term changes, but the changes are explained by using neurological adaptation. Finally, the other explanation for increased range of motion, technically speaking, is that plastic deformation. That is the difference between elasticity and plasticity. I'm sure most of us during when we have learned biomechanics, this is often explained with a strain stress curve, that there is a toe level will changes elasticity and plasticity. Plasticity often means that there is a more or less permanent change in the length, and which does not come back to its original position. That a muscle which is short often lengthens by adding more sarcomeres in its in series, right? Either by adding more sarcomeres. In some studies, they've also seen that the sarcomere length is increased. But this change, that is a permanent change, is not often reported in studies in which stretching is seen. In few studies, yes, but there are certain issues or questionable issues in that. But this is not often that is reported. But this can take place. Whenever it takes place, it happens by adding more sarcomeres in series, which is the myofibrillogenesis is the physiological explanation for that. So moving forward, we have looked into three different explanations for changes that we observe when we stretch. One first explanation is that uh, the biomechanical explanation, the temporary change, that, or what I call short-term change in stiffness or in range of motion, that we often observe clinically, is due to the mechanical properties and also due to neural adaptation, which we just discussed. But as we know that this is short-term change, and when the force is removed and the force is no longer applied, these changes also disappears. So for a plastic change, that is a muscle length moving from one point to another, or a long-term change, the change in length that doesn't return to original position, which is often our goal. So what explains that is there has to be a structural and neural adaptation. Neurological adaptation has to, structural and neurological adaptation has to take place. That would explain permanent change. So naturally, now we want to know what causes, what we can do to bring about a permanent change. Should we apply more force or longer duration of stretching? Or is there a particular training method or device available to bring that permanent change? So this is, as clinicians, we want to know, because as I've discussed before, contracture is a common problem. Stretching is a common treatment to address that problem. However, in some patients, it produces good result. In a certain group of patients, it doesn't. And often the effects are short-term, immediate release is there, but often comes out. So we are what we want to know what how we can produce permanent change. Okay, so to just summarize before I move on to reviewing evidence, these are all the three explanations that we have for changes that we see: mechanical and the viscoelastic transformation, which can change mechanical properties, increase in stretch tolerance, and neuromuscular relaxation as a neurological explanation. Structural, that is the plastic deformation, you have new myofibrils added. These are all the possible explanations for changes that can be seen. So to end this part of presentation, I want to re-emphasize that muscle stiffness, clinically, what we observe when we are making when we do a passive movement, or when patients are doing this movement with themselves, right? Clinically, what we see is not just it's not just an indicator of a muscle length, which I think we often clinically assume stiffness is often equal to shorter length. But muscle stiffness is a multidimensional phenomenon. Mechanical properties, muscle length, which is also is there, and neural control, all these factors determines muscle stiffness. So if we want to change that, and all these dimensions has to change for us to produce. So this I would like to propose this idea of learning to view muscle stiffness from a multidimensional perspective rather than just seeing it as a problem that lies within the muscle or connective tissue. Okay, so now we are moving on to the next part of this presentation. Fine, these explanations were there. So eventually, the next question is stretching beneficial or not? That's the bottom line question, I would say, because as clinicians, we want to know, does it produce the outcome that we intended? Right? So in this part of presentation, I'm going to review the contemporary evidences on effectiveness of stretching uh, in terms of different outcomes. Remember, we are stretching not just for the goal of stretching cannot just be about improving muscle length. By increasing muscle length, we eventually want to see whether the change in length improves the patient's quality of life, or in fitness or in sports, prevent injuries or improve performance. So we will see how what the evidence is pointing towards outcomes of stretching. And before that, in the current studies, different types of and methods of stretching is applied, which are also what we do clinically: self-administered, therapist-administered stretching, and also using particular devices, which included positioning, splinting, serial casting, manual stretching, and most of what we do clinically. And the type and characteristics dosage, which is often in some of the respondents to the pre-webinar survey also have asked, is there a particular dosage that would produce better results than other? So the different stretch dosage was applied in the studies, which ranged from 30 minutes to 24 hours. In some cases, they even given 15-second stretch, 30-second stretch, 60-second stretch. So all variations of timing was applied, and also stretches applied between 7 days to 6 months of stretching, which is overall the amount of stretching that is provided is 8 to 1512 hours of stretching. This is just culmination of all the research, not a one particular research. So I'm just putting everything together, how stretching was studied. So let's move on to what all stretching studies have addressed, what all the outcomes that they have addressed. And also these are all the outcomes as clinicians we want to know. That is, does stretching increase range of motion and decrease stiffness? One of the common goal of stretching. Whether stretching reduce pain, that stretch induced pain whenever reduced range of motion is stopped because of pain. So if I apply stretching, will it improve pain? Or stretching reduce spasticity? It's very specific to neurological reason, even though currently not many people are using, but this is conventionally believed that stretching reduce spasticity. So we've looked into studies which also address this question. And in sports and fitness, stretching is also used to prevent injury and performance. So does stretching does that? And activity limitation and participation restriction, basically quality of life. As I said before, eventually the stretching interventions by changing the muscle length or flexibility, eventually it has to improve patients' quality of life. Otherwise, it will have little meaning to patients. And I'm sure as clinicians, that is our ultimate goal for rehabilitation. So first question, what does the evidence suggest or shows in terms of effects of stretching in reducing pain, muscle stiffness, or improving range of motion and joint mobility? So as we have discussed before, there is immediate or short-term changes that are observed, which is clinically observable. So the evidence points that the muscle stiffness and pain associated with long excursion stretches, that is constant stretch, reduces both stiffness and pain. That is, daily passive stretch can increase. It does it by, like we discussed before, by increasing the stretch pain tolerance, that is the stretch tolerance, that there is a sensory or neurological explanation for that, which would allow for greater lengthening and lower stiffness. As we discussed before, again, I might sound repetitive, but still I want to emphasize that this outcome is due to neurological adaptation. Explanations of mechanical adaptations are not supported. However, there's a spoiler ahead. Uh, that is, when daily stretching is stopped, the stiffness which is changed with stretching often returns at the rate of 2 to 3% per day, and it returns to the level of the pre-stretch level. That is, stretching works as long as you apply it, but as soon as you stop it, the stiffness and everything comes back. This is supporting our previous my previous explanations of stretching's short-term effect. So whenever stretch is stopped, it returns. So the key is we need to find a way in which patient's activity levels are increased so that the normal or the needed flexibility is maintained. It is I can give you an example how stretching can be maintained. Is that, say for example, most of us, I don't know if I can say most of us, but I believe so, that uh, have moved on from using conventional toilet, that is Indian toilet, to a Western toilet. I believe a lot of people have now using Western toilet. So see, what happens is, if you've started using Western toilet for a considerable period of time, our body systems adapts to that demand in such a way that uh, 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 you can see that what adaptation has taken place. If you are suddenly in a situation where you have to use an Indian toilet, when you're sitting down, you will feel that your ankle is more stiffer than it used to be. Right? This is an adaptation because we have stopped squat, because as an adaptive practice, we have stopped squatting or sitting on the floor, which applied a lot of torque over the ankle, which is maintain the flexibility that is required for squatting. But once we have stopped that for a considerable period of time, your muscles or your whole system adapted to the existing demands, that is, which does not require greater excursions of ankle dorsiflexion as it is necessary for squatting. So we will find it difficult to squat because we have stopped it. So this is also a simpler explanation that when you adapt, when you change the way you perform an activity, your whole system adapts. And so this is also the explanation here: when the stretch is stopped, the system comes back to its original position. So here the solution is not to be stretching the doing stretching for whole life, but probably to adapt activity in such an extent that required functional levels of length are maintained. So the next question, this may be of interest to people who are primarily working in neurological population. Effects of stretching spasticity often used. What does the evidence says? Before looking into what the evidence says, I just want to point out that spasticity, if we can say, especially in neurological population, is primarily due to this problems or the imbalance between excitatory and inhibitory inputs. That is, inhibitory tracks are more involved than excitatory. So you, as a overall, you have a higher excitation than inhibition, which is often reflected as a increased level of tone, or clinically the stiffness, increased stiffness that we see. So why I'm pointing out here, even though it looks obvious to many people, is that the problem lies at the spinal level or at the cortex level. So which is means that spasticity is a problem. It's a adaptation to a central lesion. So if if we are targeting only on the muscles and trying to change it, even theoretically, it doesn't make much sense. However, in spasticity, because there is a lot of immobility is also associated. The stiffness that you see in a muscle in patient with stroke or cerebral palsy, it's not only because of spasticity, but also the structural adaptation in soft tissue, which could have also applied. That is the neural and non-neural component. So it's hard to distinguish once it has appeared whether the stiffness that we observe is because of spasticity or soft tissue. But the benefit of stretching in reducing spasticity is not established. That is, most of the studies, there is on systematic reviews available, a recent one, which has shown that stretching's effect on spasticity is not established yet, and probably it's not established because it is not addressing the actual problem. So yeah, it also did not show any long-term improvement as in line with the previous study results, and also changes in ADL or Ashworth scale scores or reflex ability. Nothing has changed. So the evidence points that stretching is not effective in managing spasticity. The next is injury prevention and performance. Again, this may be of particular interest for people who are working in fitness and sports level. We all know that stretching is a common exercise given as part of warm-up injury prevention, and even expected to improve performance. But here, what we need to understand is that injury risk in sports is multifactorial and to a greater extent specific to sports. And these multi-factor is determined by age and strength and a lot of extrinsic factors such as training errors, protective equipment use, and stretching, warm-up, and so on. The current evidence is not pointing towards stretching as effective in terms of preventing injuries or even improving performance. But we need to understand why it doesn't say so. Just as I just pointed out, the injury risk is multifactorial. There are so many other factors are contributing to injury. So if you're addressing only one factor, which is flexibility, and expecting that that will reduce it, it doesn't fit theoretically. So probably that may be the reason why it doesn't actually shown. So having stretching specifically used to reduce injury prevention is not supported by research. However, the existing studies are identified as inadequate in terms of population selected or methods and duration of stretching applied. So when if a training program that considers other factors and integrates, and then looked into overall injury prevention, it might show. But however, such studies doesn't exist yet. But stretching as a standalone treatment to improve performance or prevent injury does not work. That's what the current evidence is pointing to. And the last outcome, improvement in activity and quality of life. Unfortunately, many studies did not look into whether changes in length has improved patients' life, their activities of daily living, their quality of life, which is, like I mentioned before, which is often an important goal for patients, but not addressed in many studies. There are actually so many studies are done to evaluate stretching, but very, very few studies have actually looked into whether it changes their patients' quality of life, whether it changes their ability to carry out ADL. It is important, but yeah, it's not looked into. Even in few studies where they actually measure this outcome, they found that it's not improving these outcomes. So we are at the end of this presentation. I just want to summarize, okay, what does it mean? We looked into mechanisms and evidences. So as a clinician, what does it mean? And just giving a bottom line, so that just to give a gist of like a take-home message. The bottom line of the current studies finding is that effects of stretching is limited to immediate changes. That's short-term changes that we see in muscle stiffness, range of motion, and joint mobility. And it could be due to mechanical deformation, but we know that because mechanical deformation in explanation doesn't fit much, or more likely due to altered stretch tolerance or the neurological adaptation that takes place. So the effects are short term, often explained by neurological adaptation that takes place. And what we also know that the stretching did not improve patients' daily functions or performance in sports by itself, and or it did not prevent contracture or injuries. So what conclusions that I could give at the end of this presentation is that by looking at our clinical practice, we started off saying that it's one of the most commonly used treatment. So at the end, what the conclusion that I could come up with is that stretching continues to remain as a challenge for clinicians because it doesn't, the problem stays there. Stretching as a solution did not address the problem of contracture as much as we would like. It helps in certain cases, but in many areas, in a long-term changes, sustainable changes, it still doesn't produce, which means that it remains as a problem, and we do not have an optimal solution yet. For us, yes, this is disappointing, of course, because again, for the same reasons that we rely on this technique for a long, for many goals, but its effect is often short term. I think we should not be overwhelmed with this disappointment or feel negative about it. We have to take this as a challenge in learning. We have to start learning more about the mechanisms behind contracture and develop solutions. So we have to see this as the challenge for us to develop solution rather than becoming overwhelmed with the disappointment that it did not work. Our patient still needs our professional services, and we have to come up with newer solutions for that. And another important thing which I wanted to raise, which some of the researchers are also raising, is that is contracture always a problem, right? Because stretching, when we apply, we assume that whenever there is a stiffness, we have to release it. But should we always do that? Is stretching always a problem? We know that whenever after a lesion or an injury, our system trying to adapt. So this adaptation need not always be a negative one. The adaptation could be that the system is trying to adapt for the existing level of function and the capacity and biological structures that are available. So there are at times stretching, contracture or increased stiffness may be advantageous, and maybe we shouldn't be trying to release that. Say, for example, in patient with spinal cord injury, having the passive stiffness, which is increased in the ankle, can often found to help patients in standing, right? So we have to look into this. I'm not saying it helps every time, but we have to look into this and see and determine is the reduction in range of motion or increase in stiffness is actually affecting that function. We have made a lot of assumption in there, but we still do not have much studies or knowledge about when contracture becomes a problem, when it doesn't. So we need to understand that and then apply and then take that as a problem and apply solutions which to reduce it. So this is one important issue which I wanted to raise. Finally, we have to understand that contracture is not a direct result of a disease or any lesion. It is often a consequence of reduced levels of activity. So when a patient is developing contracture, our treatment often focuses on reducing this, but we have to, I would recommend that we have to shift our focus in changing this, that is the reduced activity level. If we can change that, if we can make the patients more active, then this would have a impact on it. So because it has indirect a direct connection to activity level, I would recommend that we have to explore interventions that are aimed at underlying causes, that is reduced activity, or the intervention that promote optimal adaptation needs to be explored. So this ends this webinar. Thanks to everyone for listening now. And I'll also welcome you to our next webinar in the coming Sunday on facilitation in neurorehabilitation. Mr. Hariom will be presenting this webinar. As usual, the webinar registration fee is free. So people who are interested can come back to us next Sunday also. So if you're having questions, you can type in your questions on the YouTube. On the right side of the video, there is a live comment feeds are there, or you can type in your questions in our Facebook page too. Thanks for listening once again. We'll meet again in some other circumstances.